Welcome to 2-Minute MRCP. In this video, we'll cover lithium, including its mechanism, adverse effects, monitoring, toxicity, and an easy mnemonic to help you remember everything for the MRCP exam. Lithium is a mood-stabilizing drug used mainly as prophylaxis in bipolar disorder. It is also used as an adjunct in treatment-resistant depression. Lithium has a very narrow therapeutic range of 0.4 to 1.0 millimoles per liter, so regular monitoring is essential. It has a long plasma half-life and is excreted almost entirely by the kidneys, meaning impaired renal function can quickly lead to toxicity. The exact mechanism of action is not fully understood, but there are two main theories. First, lithium interferes with inositol triphosphate, or IP3, formation, affecting intracellular signaling. Second, it interferes with cyclic AMP, or CAMP, formation, altering neurotransmitter activity. Now let's look at the adverse effects. An easy way to remember them is the mnemonic lithium, which applies to therapeutic levels between 0.4 and 1.0 millimoles per liter. L stands for leukocytosis and lethargy. I stands for idiopathic intracranial hypertension. T stands for fine tremor, which is common at therapeutic levels, and T-wave flattening or inversion on ECG. H stands for hyperthyroidism, due to thyroid enlargement, and hyperparathyroidism, which can lead to hypercalcemia. The second I stands for diabetes insipidus, specifically nephrogenic diabetes insipidus, causing polyuria due to nephrotoxicity. U stands for upset tummy, including nausea, vomiting, and diarrhea. And M stands for metabolic weight gain. Now let's discuss monitoring, which is a favorite MRCP topic. When measuring a lithium level, the blood sample should be taken 12 hours after the last dose. After starting lithium, or after every dose change, measure lithium levels weekly until they become stable. Once established, check lithium levels every 3 months. After a change in dose, lithium levels should be taken a week later and weekly until the levels are stable. Renal function and thyroid function should be checked every 6 months. Patients should also receive a lithium information booklet, an alert card, and a record book to improve safety. Now let's move on to lithium toxicity. Lithium toxicity usually occurs when the serum lithium concentration is greater than 1.5 millimoles per liter. Common triggers include dehydration, renal failure, and several important drugs. The key drugs to remember are thiazide diuretics, which are the most important, AC inhibitors, angiotensin receptor blockers, NSAIDs, and metronidazole. These drugs reduce lithium excretion and increase the risk of toxicity. Remember the features of toxicity with the mnemonic TRUX. T stands for coarse tremor. Remember, fine tremor occurs at therapeutic levels, while coarse tremor suggests toxicity. R stands for increased reflexes, or hyperreflexia. U stands for increased urination, due to nephrogenic diabetes insipidus. C stands for confusion, which may progress to coma. And S stands for seizures. Finally, let's discuss management. For mild to moderate toxicity, stop lithium immediately and begin intravenous isotonic normal saline to correct dehydration and restore renal perfusion. Continue IV fluids until the patient is euvolemic, then usually continue at twice the maintenance rate. Monitor serum sodium every 4 hours with serial lithium concentrations, especially if nephrogenic diabetes insipidus is suspected. In severe toxicity, hemodialysis is the treatment of choice, as lithium is effectively removed by dialysis. Sodium bicarbonate has been used to alkalinize the urine and increase lithium excretion, but the evidence supporting its use is limited. That's everything you need to know about lithium for the MRCP exam. Thanks for watching 2-Minute MRCP. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.